So Barry, what about the chronic patients, the patients that they will have dizziness for weeks, months, or years even?
The way to proceed with these patients is always to try and find the underlying diagnosis. Virtually always there is either one or more underlying dizzy diagnoses that are amenable to treatment. Mm-hmm. So one of the causes of chronic dizziness is a failure to treat the underlying causes. The second cause of chronic dizziness is drugs inappropriately used to treat dizziness can actually promote continuing dizziness. And then finally, the last thing is that when patients have an untreated vestibular disorder, there are maladaptive responses to that from the brain, which in fact, rather than making things better, make things worse. And this not only makes the patient not leave home and have more symptoms, it also is very confusing to the doctor because they don't understand quite what's going on. So we will have a section about rehabilitating the chronic dizzy patient, but the first step is to look for underlying dizzy diagnoses. And what are the common dizzy diagnoses that lead to chronic dizziness? The first one is benign paroxysmal positional vertigo. I think the record in my clinic is I've had a patient with recurrent BPPV for 15 years, undiagnosed and untreated. I'm sure other people in the field have had patients with longer histories. And this patient responded to treatment. Now, this particular patient not only had recurrent BPPV episodes, but also had a feeling of dizziness that was continuous. So how do I explain that? How do I have a patient with a recurrent dizzy diagnosis and continuous dizziness? And that sort of defeats the doctor's logic as to understanding what's going on. And the continuous dizziness was the maladaptive response from the brain trying to sort out this recurrent dizziness. And these patients have problems with tolerating visual motion, or they have problems with self-motion. They become motion sick. And these patients will complain of dizziness when they go out in a shopping mall or when they go out and a train moves past. So what do? They stay at home. So we will talk about how to treat these patients, but the first step is to treat the underlying disorder, and the second step is to refer to specialist rehabilitation services.
And I can then make this diagnosis in general practice.
So we would encourage GPs to look for these common diagnoses like BPPV. The second common one in this situation is migraine. Bear in mind that migraine can cause vertigo, often without coexisting headache. So the typical migraine patient will have, in my clinic anyway, where the presentation is somewhat atypical, will have had migraine in the past, and they start developing dizzy episodes, typically without headache. And then we try and look for other causes of dizziness. We exclude all these other causes, and we are left with a diagnosis of potential vestibular migraine. And then we consider treating this with anti-migraine drugs. Of course, they are the easy cases. The easy cases constitute patients with recurrent episodes of headache, photophobia, phonophobia, and dizziness. Well, that's a no-brainer. You know it's migraine. But failure to treat these patients' migraine with anti-migraine drugs will lead to prolonged symptoms. Just a word of warning, we will touch on drugs like Stemetil. Stemetil is a pretty effective anti-migraine drug. So many patients with recurrent migraine will gain symptomatic benefit from Stemetil, and GPs will gain some reassurance, the patient's responding to Stemetil. So they're probably treating recurrent vestibular migraine, but treating patients with long-term Stemetil is not healthy for the patient because it's a dopamine antagonist that will impair balance function, particularly in the elderly.